Hello, Pritish. Hello.
Yes, ma'am.
Does he want to share the screen and share?
Yes, ma'am.
So tell him to do it.
Okay.
Hello.
Yes, sir.
Yeah, am I audible? Hello.
Yes, sir. You are audible.
Yeah, okay. You want me to share the screen?
Yes, sir.
You want to check out how to share, na? So just
Yes.
Yeah.
Yes, ma'am.
गुड इव्हनिंग मॅम.
Good evening.
पाटील बोलतोय.
बोल संदीप. प्रीतिशला म्हणलं स्क्रीन शेअर कर. It is being seen well, no problem.
Seen well?
Yeah, seen well. Yeah.
Okay.
तर मॅडम मी दिसतोय का? एम आय विजिबल?
हो, तू ऐकू तर येतोयस व्यवस्थित आणि दिसतो पण आहेस. पण आता प्रीतिशनी स्क्रीन शेअर केल्यामुळे
मी लांब गेलेलो आहे.
एक्झॅक्टली. आता जो बोलेल तो दिसेल. बाकीचे जर आपण व्हिडिओ बंद ठेवलेले बरे असतात, म्हणजे इंटरनेट कनेक्टिव्हिटी व्यवस्थित राहते आणि बाकीचे काय आवाज बिवाज येत नाही. बाकी काही नाही.
मॅम माझं शेअर करून बघू, मला दिसतोय का?
हो ऑफकोर्स शेअर करून बघ ना. आता ह्याला बाहेर निघावं लागेल स्क्रीन शेअरच्या आणि मग तू शेअर करू शकतो.
ओके, मी शेअरिंग स्टॉप करतोय.
हो
मॅडम, गुड इव्हनिंग.
हो सुप्रिया, तू विसरली आम्हाला.
मॅडम काही पण कधीच नाही.
बघ ना, मग काय.
कधी कशी विसरणार आहे मी, नेहमी आठवण काढते.
आणि ज्या दिवशी तू ऍक्च्युली तू बोलणार हे मला संदीप बनला त्याच दिवशी तुझी आठवण काढली होती.
हो का?
प्रवीण देवखाते बरोबर बोलत होते.
ओके.
मला काय तुझ्या नवऱ्याचं नाव आठवेना. अरे ते आमच्या सुप्रियाशी लग्न केलेलं तो कुठे रे आता, असं मी विचारलं.
आणि तो बरा आहे का?
हो.
ठीक आहे मॅडम, मला आठवण येत असते नेहमीच.
संदीप तुझा स्क्रीन.
मी बाहेर आलो.
तू बाहेर पण आलास. सुप्रिया एकदा बघ तुझा.
हो. मॅडम दिसतंय?
हो दिसतंय. इट्स वेल सीन, नो प्रॉब्लेम.
ओके थँक्स मॅम.
या
आय एम स्टॉपिंग शेअरिंग.
या यू स्टॉप शेअरिंग.
आज ते माझ्या मते एओराचं पण काहीतरी आहे ना, अकॅडमिक सेशन.
अरे आता कसं आहे, बऱ्याच गोष्टी आता वेबिनार असल्यामुळे असतातच. आता ते कळतं नंतर आपल्याला. आपण काय आपले आर थिंग इज फॉर आवर मेंबर्स. आता वी कॅनॉट डू मच अबाउट दॅट.
येस मॅम.
बिकॉज एव्हरी डे देर इज समथिंग ऑर द अदर. तरी त्यात बाकीचे जे महाराष्ट्राचे ब्रांचेस आहेत त्यांचं काही नाहीये ना, एवढं आम्ही बघतो. आता त्याच्या पलीकडे आता एवढाच काहीतरी असेल, अजून OBGY वाल्यांचं काहीतरी असेल. आपण काय काय करू शकणार ना शेवटी.
वेबिनार असल्यामुळे इट इज लाईव्ह एव्हरीवेअर.
येस एक्झॅक्टली.
पूर्वीसारखं असं फिजिकल अटेंडन्स आणि याच्यामुळे ते लोक थोडी तरी शेअर करायची. आता अवघड.
म्हणून एक्झॅक्टली. आता पुढे थोडे दिवस करू आपण फिजिकल गोष्टी.
येस मॅम.
कारण आता आहे म्हणजे पॉसिबल.
येस मॅम.
करू आपण जोपर्यंत करता येते. आता मार्च मध्ये GDM आहे. आपण त्या दिवशी बोलत होतो, तर एक 12 मार्चला वगैरे असं ठरवतोय.
12 मार्च. ओके.
तर बघू काय होतंय. जरा 1-2 दिवस लागतील मला ते फायनल व्हायला.
ओके
चालेल. आता मी घरी पोहोचलेच नव्हते अजून, पण मला तुमचं स्क्रीन शेअर करायचंय म्हणून मी
तुम्ही मोबाईलवर आहात?
लॉग इन, हा मोबाईलवरनं मी लॉग इन केलंय.
तुमचं
हा.
चांगलं आहे म्हणजे क्लॅरिटी तुमचं याच्यात कुठलं तुमचं
हो
नेटवर्क
हो चांगले.
आयडियाच आहे का?
नाही माझं जिओचं चालतं व्यवस्थित.
मला
आयडिया
आश्चर्य
माझं ते
वाटलं.
नाही, वोडाफोन आयडिया नाही चालत रे, माझं नाही
हो.
चालत ते.
नाही
जिओचं
चालत.
चालतं.
त्रास देतो खूप ते.
ते खूप जास्त देतं. चालेल, मग मी आता थोडं माझा ऑडिओ बंद करते आपलं हा,
येस
आणि
मॅम, येस मॅम,
लॉग इन होते परत. हा
येस मॅम,
ओके.
येस मॅम.
हा,
थँक्यू मॅम.
सुषमा जॉईन इन होतीच आहे, मी पण होतेच. ओके.
हो.
मॅडम मी
Okay.
आहे,
Thank you.
मी
हा,
login
आली
केलंय.
सुषमा आली. हो. हा.
सुषमा मॅडम, गुड इव्हनिंग.
हॅलो, गुड इव्हनिंग सर.
माझं मी दिसत नाही का मला?
सर
सर
तुम्ही व्हिडिओ ऑन केलाय?
स्टार्ट व्हिडिओ करा सर खाली.
आणि माझा व्हिडिओ ऑन आहे.
सर पण नाही दिसत आहे तुम्ही.
नाही दिसत आहे का मी?
नाही सर.
मगाशी संदीप तू दिसलास मला पण.
हो का?
हा.
मी एक्झिट येऊन परत इन होतो. बघूया.
हो सर, हो सर.
चालेल.
तर आता दिसतंय तुम्ही?
हो हो, माझं ते क्विक हिल वाल्याने थोडस थांबवून ठेवलं होतं. जा.
ओके, ओके सर.
हाऊ इज ससून डुईंग? सुषमा मॅडम,
सर ठीक चालू आहे, व्यवस्थित आहे.
लिस्ट कधी असते म्हणजे जास्त शनिवारी वगैरे कमी असं काही नाही तसं काही?
नाही सर, असं काही नाही. म्हणजे आता सध्या तर मी इन्फोसिस ओटी मध्ये आहे, तर म्हणजे असं काही फरक नाहीये. एव्हरी डे वी हॅव केसेस.
अँड इन्फोसिस मध्ये विच ओट इज सुपर स्पेशालिटी? ऑल सुपर
हा
स्पेशालिटी?
सर, युरोलॉजी, त्याच्यानंतर म्युकर मायकोसिस आहे, पण आता कमी झालेत पेशंट सर. लास्ट
Okay.
2 वीक्स पासून नाही झालंय. न्यूरो आहे आणि प्लास्टिक आहे. सो 2 days इन अ वीक.
ओके ओके, चांगलं आहे. आणि कार्डियकचं पण चालूच आहे ना आपल्या
हा, कार्डियक तर चालूच आहे सर. लोंढे सर आहेत तिकडे, म्हणजे वेगळे येतात अॅनेस्थेटिस्ट.
बरोबर, अविनाश येतो. आणि कॅथलॅब पण चालू आहे आपली?
हो सर, कॅथलॅब पण चालू आहे.
तिथं कोण काडरे सर होते
तिथे
पूर्वी, आता कोण?
डॉक्टर हेमंत कोकणे म्हणून आहेत.
हो,
इज अ लेक्चरर. हा
बरोबर.
ते आहेत तिकडे.
आणि पेन क्लिनिक चालू आहे आपलं?
हो सर, पेन क्लिनिक चालू आहे.
Good.
म्हणजे माधुरी लोकापुरे मॅडम नाही आहेत सध्या, पण मग आमच्या इथे जे आहेत पेन फेलोशिप घेतले विनय मॅडम, नेहा मॅडम बघतात ते.
गुड गुड गुड. We will start around 6:30.
हो सर, आपण म्हणजे बघू, म्हणजे थांबू अजून आपण थोडं. मॅडम जॉईन, म्हणजे मॅडम आहेत प्रज्ञा
नक्कीच
मॅडम.
नक्कीच, प्रश्नच नाही.
आपण
या. ही मीटिंग रेकॉर्ड करता येते का आपल्याला इंडिव्हिज्युअली पण?
सर लाईव्ह स्ट्रीमिंग आहे ना सर, युट्यूब वरती.
इथं चालू असतं.
रेकॉर्डिंग पण करता येते. मीटिंग स्टार्ट झाली की मी स्टार्ट करेल.
ओके ओके, चालेल चालेल.
संदीप, अजून आपण एक 5 मिनिटं थांबू, कारण अजून लोक जरा जॉईन होऊ दे.
येस मॅम.
हा,
शुअर
5 मिनिटं थांबू अजून आपण.
हो हो.
तू चांगला दिसतोय सर मला आता.
थँक्यू. खरं झूम मीटिंग आणि याच्यामुळं द सिनेरिओ हॅज चेंज. आय थिंक ऑल फ्युचर कॉन्फरन्स विल बी लाईव्ह ॲज वेल एज, म्हणजे इंटरनेट झूम मीटिंग होतीलच ॲज वेल एज फिजिकल मीटिंग.
हायब्रिड
हायब्रिड स्टेटस असेल सगळ्यांचं. आणि ज्यांना कोणाला अटेंड करता येत नाही दॅट इज गुड फॉर देम, इस्पेशली नॅशनल लेवलच्या इंटरनॅशनल लेवलच्या कॉन्फरन्सेस.
अगदी बरोबर. सुषमा, बरोबर 6:35 ला वी विल स्टार्ट.
ओके मॅडम.
स्वयंपाकाला सुट्टी असते. Sushma, ready?
Yes, ma'am.
Yeah.
Yeah. Can we start, ma'am?
Right?
Yeah. Can we start, madam?
Yeah. Yeah, please start.
Okay. Good evening, respected faculties, teachers, and colleagues. ISA Pune City branch has organized a webinar in association with the Anesthesia Associates and Joshi Hospital. The topic or the title of the webinar is a cardiac case for the non-cardiac surgery, a few concerns. So let's begin with the session now. Our first presenter is Dr. Pritish Kumbhare. He is a pediatric anesthetist and consultant at Anesthesia Associate Group. His special area of interest are oncoanesthesia and pediatric anesthesia. His topic for the day is the clinical physiology of cardiac output. So I request Dr. Pritish Kumbhare to start with the topic.
Thank you, ma'am, for the introduction. Okay, good evening, everybody. Let's discuss about the clinical physiology of the cardiac output. So firstly, to begin, as we know, the definition of the cardiac output is the amount of the blood which is being pumped out by the left ventricle in 1 minute. So to calculate the cardiac output, you multiply the stroke volume by the heart rate of the person. So in a normal adult person, if we take the resting heart rate of around 70 beats per minute and the stroke volume of 70 ml, 70 mLs, the approximate cardiac output that we get is somewhere around 5 liters. Now, what is ejection fraction? So as you know that a heart doesn't pump out the complete blood, it pumps out the volumetric fraction of the blood of the end diastolic volume. So the ejection fraction is the volumetric fraction of the blood pumped out from the left ventricle in each contraction. Now to find out the ejection fraction, we divide the stroke volume by end diastolic volume. So if a stroke volume is around 70 mLs and the end diastolic volume of 120 ml, we get the ejection fraction of somewhere around 58%. Normal ejection fraction ranges somewhere around 55 to 65%. So as you can see, a normal resting heart, we are getting an ejection fraction of somewhere around 54% with a stroke volume of 70 mLs and the end diastolic volume of 30 mLs. So if the person is exercising, you see this stroke volume has increased up to 120 ml and then the end diastolic volume has gone up to 133 ml, giving us ejection fraction of around 90%. Now, what are the factors that affects the cardiac output? So mainly 4 factors: preload, afterload, contractility, and the heart rate. What is preload? So preload is determined by the volume of the blood in the left ventricle at the end of the diastole, which mainly depends on 2 factors. Firstly, the venous return of the heart. More the venous return, more is the preload, and more is the cardiac output, and vice versa. Secondly,
Pritesh, please
yes,
start your slide show. It is only a thick slide we are seeing.
no, it is already on, sir.
Are you moving your slides ahead?
Yes, I'm moving. I'm moving also.
One slide.
Which
Now
we can. Now we can.
so I'll stop the slideshow. I'll present it with like this only.
Okay.
Okay.
No, yeah.
Okay. Okay. So the preload, I've changed the slide. Can you all make it out?
Yes, now slides are seen.
Okay.
Yes.
Okay. So the preload is a degree of the stretch of the cardiac muscles just before the contraction, and it is governed by the Frank-Starling law of the heart. Let us discuss in detail what is the Frank-Starling law. So Frank-Starling law gives us the relationship between the the stroke volume and the end diastolic volume or the pressure. The law states that the stroke volume of the heart increases in response to the increase in volume of the blood in the ventricle before contraction. So as you can see, this red line, this is a normal functioning heart, and at rest, there is an increased stroke volume with the increased end diastolic pressure. Now consider a condition where you have an increased demand, like person is exercising, you'll have a fall in peripheral vascular resistance, increase in heart rate, and increase in contractility of the heart. In this situation, the graph will move up and to the left side. Similarly, so if you have a decreased demand, like the patient has got a hypoxia or acidosis, or there is a heart failure, the graph will move to down and to the right side. Now, as we said, if we are keeping the factors constant, we'll get the linear graph. Now consider a condition where you have a patient with a heart failure. We have plotted a graph of the stroke volume to the end diastolic pressure in a patient with a heart failure. You can see there is a short linear curve with a long plateau phase. Now this patient is at a point B. Now if I have to decrease the preload by giving diuretic to the patient, the heart will come back to the point C, which is at more linear phase and in the functional state. Secondly, if I have to decrease the afterload of the patient by giving ACE inhibitors, I'll be decreasing the peripheral vascular resistance of the patient. Now you can see now point B has moved to point D. Now at the same EDV, now I'm getting the more stroke volume because the heart has to work with the less peripheral vascular resistance now. Next, if you have to increase the contractility of the heart by giving the drug which increases the contractility, like dobutamine or digitalis, you need to decrease the EDV, but you can increase the contractility at the same point of EDV. At the same EDV, you will get a increased contraction of the heart. Let's quickly see what are the factors which increase or decrease the preload. So IV fluids or blood, hypervolemia in early cause will cause the increase in preload. Bradycardia will cause more filling and will increase the preload. Any mitral or tricuspid valve regurgitation will increase the preload, and the vasoconstrictors, example norepinephrine, will cause increase in preload. Dehydration in any form, hypovolemia or volume loss will cause the decrease in preload. Tachycardia will again cause the less ventricular filling and will cause decrease in the preload. Any valve stenosis will cause fall in preload. Vasodilatation, nitrates will cause fall in preload, and diuretics, of course. So what is afterload? So the afterload is a pressure that heart must work against to eject the blood out of the blood, and it is proportional to the arterial pressures and the diameter of the arteries. As the pressure increases, the resistance was increased and resulting into increased afterload. Now there are factors which affect this afterload. So pulmonary or aortic valve disease like stenosis will cause increase in the afterload. It will be increased work for the heart to pump the blood out of the heart. Again, the viscosity of the blood. Polycythemia, patients with polycythemia will have increased afterload. Similarly, any drugs which is causing vasoconstrictions will have increased afterload. Afterload to left ventricle, it is an arterial pressure, and to the right ventricle, it's a pulmonary artery pressure. Now, next, contractility. It is the intrinsic strength of the cardiac muscles. So, a positive inotropic drug increases the contractility by increasing the calcium influx due to sympathetic response. Hormones like thyroxine, glucagon, and epinephrine will increase the contractility. Drugs like dobutamine and digitalis increases the contractility. Negative inotropic effect decreases the contractility. The factors like acidosis, hypoxia will decrease the contractility. Similarly, drugs like calcium channel blockers will decrease the contractility. Finally, the heart rate. There are few factors which influence the pulse rate. So a short-term exercise would increase the pulse rate. In fact, but the person who has got a heart conditioned by the long-term exercises, like in athletes, there will be a bradycardia. So fever, temperature, or hyperthermia will cause rise in pulse rate, but hypothermia will cause fall in pulse rate. So emotions like sympathetic response as fear, acute pain, anxiety will cause rise in heart rate, whereas parasympathetic stimulation like deep breathing or relaxation will cause fall in a pulse rate. Chronotropic drugs like epinephrine will cause the rise in heart rate. Sympathetic any blood loss will cause a sympathetic reflex sympathetic stimulation and will cause rise in the blood pressure, the heart rate. Postural changes like standing or sitting will cause increase in the pulse rate, whereas if in the lying down position, the pulse rate would come down. Thank you.
Thank you, Dr. Pritesh, for the wonderful and informative session on physiology of a cardiac output. Now, before moving ahead, I would like to make a small announcement for all participants. If you have any questions for this session and the remaining session, please put it in the chat box so that we can do it at the end of our presentation. Now we move to our next speaker, Dr. Sandeep Patil. Sir is a cardiac anesthetist and director and consultant at Anesthesia Associate Group. His topic for the day is anesthesia management in patient with low ejection fraction. So I request Dr. Sandeep Patil to start with his topic.
Thank you, Dr. Sushma. Good evening, everybody, and greetings from my group, Anesthesia Associates. First, I would like to say thank you to Pradna Madam, our President of Pune Branch ISA Society, and all Executive Committee members for giving us opportunity to present this webinar. My topic of today's webinar is anesthesia management in patients with low ejection fraction or patients with heart failure. February is supposed to be the month of love, a time for Valentine's Day and remembering love. And when you say about something about love, the heart comes. In America, February is the month that is called as American Heart Month. And there are a lot of activities all over America to increase the awareness of heart diseases in the society. So our today's topic is very much in relevance to this month of February, that is Heart Month. Heart acts like pump to generate cardiac output. It has systolic and diastolic functions. Ejection fraction is the commonly used marker for systolic dysfunction. there has to be some cardiovascular disease which leads to low ejection fraction or systolic dysfunction, and which leads to altered physiology in our body. Ejection fraction is graded as following. If EF is greater than 70% is hyperdynamic, 50 to 70% is normal. Mild dysfunction is there when the EF is 40 to 49%. 30 to 39% is moderate dysfunction, and less than 30% is severe decrease in ejection fraction. This is always a progressive condition from mild to severe dysfunction in ejection fraction. What are the causes of low ejection fraction? Ischemic heart disease, cardiomyopathy, valvular heart diseases like aortic stenosis, hypertension, alcoholism, and so on. So why we are worried about low ejection fraction? Low ejection fraction is a long-term risk factor for death in patients undergoing elevated risk non-cardiac surgery. In 25% of patients with EF less than 30%, acute exacerbation of heart failure takes place. There are a lot of compensatory mechanisms when one starts developing heart failure. What are the clinical manifestations in low ejection fraction? Initial stages, patient may be asymptomatic when the compensatory mechanisms are active. When patient starts developing low ejection fraction symptoms, they are basically of systolic heart failure, or there may be some arrhythmias. Heart failure may be right-sided or left-sided or both. It may be acute or chronic, or acute on chronic. It may be decompensated or compensated. There are a lot of symptoms and signs. We know them. The American College of Cardiology and American Heart Association has classified heart failure in 4 stages. Stage A is when the patient has only some risk factors for development of heart failure, like diabetes, hypertension, ischemic heart disease. There are no structural heart changes and no clinical heart failure. In stage B, there are structural heart changes like left ventricular hypertrophy or dilatation of the chamber and reduced EF, but patient doesn't have clinical signs and symptoms of heart failure. In stage C, patient now has developed clinical heart failure, and in stage D, patient has refractory heart failure who requires advanced intervention. The symptomatology of low ejection fraction heart failure can be classified by NYHA from class 1 to class 4. The treatment of heart failure is as follows. Stage A, the patients without structural heart changes and without clinical heart failure, we have to just control all the risk factors. In stage B, we have to add angiotensin converting enzyme inhibitor plus beta blocker and some antiarrhythmic agent. In stage C, we have to add a diuretic, then a drug like valsartan plus sacubitril, that is angiotensin receptor neprilysin inhibitor. In selective high-risk patients, there is treatments like cardiac resynchronization therapy. When patients are in cardiac failure, the patients have dilated hearts. Both ventricles may not be contracting at the same time, leading to asynchrony in their contraction. So we have to put a triple chamber pacemaker, and that is called as cardiac resynchronization therapy to augment the ejection fraction. And in some patients due to dilated hearts, they are prone for tachyarrhythmias like ventricular fibrillation, ventricular tachycardias. So in them, the ICD, internal cardiac defibrillator, is a treatment of choice. Stage D patients who are in refractory end-stage heart failure, they are given VAD, that is ventricular assist devices, or they are posted for heart transplant. When a patient of low ejection fraction or heart failure comes to you, we have to evaluate them both clinically and by investigation. Clinically, by taking history and clinical examination, we can grade the patient according to NYHA, class 1 to class 4, and stage A to stage D as per ACC to ASC classification. Investigations are for diagnosis of heart failure. What is the cause of the low ejection fraction and what is the severity of that? There are a lot of investigations. The commonest are the X-ray test. According to severity of low ejection fraction and heart failure, there are a lot of signs on the X-ray like cardiomegaly, cephalization of blood flow, curly A and B lines, interstitial edema, pleural effusion. In electrocardiogram, there are arrhythmias, conduction abnormalities, left ventricular hypertrophy, ischemia, infarction. Echocardiography is the most useful non-invasive test in the assessment of left ventricular function. It provides an objective assessment of cardiac structure and function. Now, when you are doing echocardiography and reading a report of echocardiography, most of the time we see only ejection fraction. Yes, of course, it is the important parameter that we have to evaluate. Ejection fraction gives grading of the severity of systolic dysfunction of the heart. But apart from ejection fraction, we have to see a lot of things, and there are a lot of things in the ejection echo report. First of all, we can see the chamber dimensions and the structural changes. They are there in the M mode reporting of the echo report. We can see dilatation of the heart's chambers, then hypertrophy, whether it is concentric or eccentric. The septum to left ventricular posterior wall thickness ratio of 1.3 or more than that, it suggests concentric left ventricular hypertrophy. Then what may be the cause of low ejection fraction? If there is regional wall motion abnormality, it is something suggestive of ischemic heart disease. And if there is global hypokinesia, then it may be a sign of dilated cardiomyopathy. Then valvular abnormalities, aortic stenosis leading to left ventricular dysfunction. Mitral incompetence is a consequence of dilated left ventricle. The mitral wall may be normal, but due to dilatation of the left ventricle, the annulus also gets dilated and the normal mitral wall becomes incompetent. That is called as functional mitral incompetence. Then due to decreased left ventricular function, what are the back pressure effects like left atrial dilatation, pulmonary hypertension, right ventricular dysfunction? Then there is a subset of patients where the ejection fraction is normal, but the patient is showing clinical signs and symptoms of heart failure. So these are the patients known as heart failure with preserved ejection fraction. It is due to structural and function signs changes in the left ventricle. There is left ventricular hypertrophy, diastolic dysfunction leading to clinical signs of heart failure. These are some clips of normal ejection fraction and reduced and ejection fraction on the higher side. This is a parasternal long axis view, transthoracic echo, where you can see this is a left ventricle, and this is a mitral anterior leaflet which is touching the septum. In contrast, in reduced EF, the anterior leaflet is not able to touch this septum, and you can see visually that the left ventricle is contracting very less. In contrast with left ventricular hypertrophy, the walls are very much thick and there is higher ejection fraction. So what I've told regarding this echo report, you can extract a lot of information from the echo report, and that will help you in the management of these patients perioperatively. You can see the left atrial size, the left ventricular diameter in diastole, in systole, then posterior wall thickness, right ventricular ejection fraction. Then we can see what is pulmonary hypertension. So all these things will help you in management of these patients. Something about FATE, that is focus assessed transthoracic echo. This is sort of a bedside point of care echocardiography. There are basic 5 views, and this examination of the patient can be done within few minutes, and you can diagnose some cause of hemodynamic instability in the ICU in the perioperative period. So there are 5 views like subcostal 4th chamber, apical 4th chamber, parasternal long axis, parasternal short axis, pleural scanning. So these views will help you in knowing what is the reason for hemodynamic instability in the perioperative period by using these 4 views. Now this is a short axis of the left ventricle, where you can see the cavity of the left ventricle and the ventricular wall. The contractions will tell you what is the contractility of the left ventricle, whether there is any regional wall motion abnormality, how is the feeling of the left ventricle. This is the long axis parasternal view, where you can see the aortic wall, whether there is some element of stenosis. We can put a Doppler and we can see the gradient. This is also a very important view for us, in which you can see the IVC enter into right atrium. We can see the collapsibility of the IVC and the diameter of the IVC. Accordingly, we can judge what is the preload of the heart. There is a new parameter nowadays. It is called as left ventricular global longitudinal strain. It measures the maximal shortening of the myocardial longitudinal length during systole compared to the resting length in diastole. It is more sensitive than ejection fraction for systolic dysfunction, and the normal value is -16 to -22. So there is a software where to feed in your echocardiogram machine, and it will tell you which are the segments which are less contracting, and so accordingly we will come to know what is the status of the left ventricle. In hematology and biochemistry investigations, anemia as a cause of breathlessness, or it may be a cause leading to high output failure. The dilutional hyponatremia is a marker of severity of chronic heart failure. Due to high dose of diuretics, hypokalemia, hypomagnesemia may be there. Hyperkalemia is present in patients with low GFR, use of angiotensin converting enzyme inhibitors and potassium sparing diuretics. Serum creatinine may be elevated in high doses, patients taking high doses of diuretics or patients taking angiotensin converting enzyme inhibitors. Liver function tests may be abnormal due to hepatic congestion. In patients with low cardiac output, your ABG may be showing metabolic acidosis. The diagnostic test for heart failure is BNP or NT-proBNP. These are the peptides released from the heart wall due to dilatation or distension, and they differentiate from a patient from a cardiac cause apart from the respiratory cause. So these are very sensitive markers of heart failure, and they have also some prognostic value. If the proBNP values are coming down, your patient is stabilizing. So when a patient is posted for some surgery, and if the patient has previous history of cardiac failure and is settling, is taking treatment in the ICU or CCU, so we have to see the trend of proBNP, whether it is going down, and if it settles down, then the optimizer is good and the patient is very, very well optimized. Regarding the other states for knowing the cause of low ejection fraction, test thallium, angiography, cardiac catheterization, and myocardial biopsy, there are various investigations. Now coming to anesthesia management of patients with low ejection fraction or heart failure. In pre-operative assessment, like any other case, depending on the history taking and clinical examination, we can have following information: whether our patient's heart disease is compensated or decompensated, whether there is evidence of decompensation in last 6 months of surgery, because that is associated with increased risk. What is the effort tolerance NYHA classification of the patient in MET equivalents? What is the history of associated comorbidity like ischemic heart disease, hypertension, diabetes? Now, depending upon the clinical assessment and investigations, we can have some risk calculator or risk assessment of the patient for this perioperative period. And we have to talk with the patient and the relatives about patient's plan of anesthesia and the risk involved in the anesthesia and surgery. If our patient is compensated heart failure patient, it goes into ASA grade 3, and if it's decompensated, it is ASA grade 4. There is another risk indicator we use normally in our institute, that is revised cardiac risk index. There are 6 parameters, and one of the parameters is history of heart failure. So if our patient is posted for some major surgery, then there are 2 factors now. One is major surgery and the other is history of heart failure. The incidence of MACE, that is major adverse cardiac event, that is migraine infarction, pulmonary edema, VF, cardiac arrest in the perioperative period is almost 6.6%. So we can tell the patient's relative what may be the chances. Not most of the time the patient's relative will ask what is the chance of complication. So we can tell something about like this, 6%, 11% using this revised cardiac risk index. Now what our physician or cardiologist will help us. Their role is basically to optimize our patient's medical therapy and to minimize symptoms of left ventricular failure and maximize functional capacity. Most of the anti-failure therapies should be continued in the perioperative period. Concern is about only angiotensin converting enzyme inhibitors. They may cause precipitous fall in blood pressure if you are going to give spinal anesthesia. Resting tachycardia, symptomatic arrhythmias, atrial fibrillation should be treated and attempts made to control heart rate at around 80 beats per minute. Elective surgery should always be postponed until medical management has been optimized and risk assessed thoroughly against benefit. Coming to interop management, when you are managing these critical patients, you are doing two jobs. You are giving anesthesia, that is one job, and the other one is managing these critically ill patients, that is a job like intensivist or physician. So we are not superman or superwomen. So there should be always some expert help in the form of your fellow colleague anesthesiologist or some senior person who will be helping you in your anesthesia management. Then I should ask myself some questions. What is the present physiology of this patient? How my anesthesia will affect the hemodynamics? And how I am going to manage that? What is my plan of action? So there are some aims of hemodynamics. Preserving cardiac output. As already Pritesh told you, there are three factors of cardiac output: preload, afterload, and contractility. In these patients, due to poorly contractile ventricle, a higher than usual CVP is necessary, around 8 to 12. You should avoid tachycardia because tachycardia decreases the diastolic time. And if the diastolic time decreases, the filling of the ventricle will be hampered. Atrial kick has to be preserved because the atrial kick, the proportion of cardiac output it is contributing is almost 30% in the cardiac output. You should give intravenous fluids judiciously. Afterload increase should be always avoided, and contractility should be preserved by judicious use of anesthesia agents and using various inotropes. You should minimize myocardial workload by effective analgesia and use of regional techniques, by giving good anesthesia and regional anesthesia techniques, and prevent sympathetic stimulation. Electrolytes like potassium, magnesium should be in the normal range. Hypokalemia, hypomagnesemia, they increase the irritability of the heart. Metabolic acidosis depresses the myocardial function. Same with hypothermia. So we have to take care of these two things. When I'm working in institute and I'm managing these kind of patients, I should have a good infrastructure, good gadgets in my operation theater. First of all, a good workstation with a good multi-para monitor having a facility of invasive monitoring. Then there should be a defibrillator, syringe pumps, all cardiac drugs, pacemaker, and BIS monitoring. When I'm using an invasive monitor, invasive blood pressure or central pressure, additional information out of the radial arterial waveform that I will get. This is just additional information for all of the participants. When you see a radial artery waveform or any artery waveform, there are systolic upstroke and systolic downstroke. When the slope of this is very steep, so it is a marker of a good contractility. Then position of the dichrotic notch. If it is on the higher side, it is pathognomonic of vasoconstriction. If it is on the lower side, it says there is a vasodilatation. The area under the curve will tell you what is the intravascular compartment volume. So very narrow radial artery tracing, which suggests there is vasoconstriction, less intravascular volume. Now this is a monitor called as flow track or EV1000 monitor. It is by Edwards Life Sciences. This is monitor semi-invasive method of calculation of cardiac output, stroke volume, and preload. There is a special transducer which is connected to radial artery catheter. A complex algorithm fed into the monitor, which analyzes the artery waveform, and it calculates the stroke volume on bit-to-bit basis and stroke volume variation. It also calculates cardiac output and SVR. So the principle behind this monitor is that when the patient is on mechanical ventilation, the prerequisite for using this SVV, stroke volume variation, is that patient should be mechanically ventilated. At least 8 to 10 ml per kg of tidal volume should be there. So during respiratory cycle, there is stroke volume variation. And if the stroke volume variation is more than 15, then it says that the patient is hypovolumic and patient has to be given fluids. And if the stroke volume variation is less than 8, it means your patient is having good intravascular compartment volume. So SVV should be maintained around 8 to 15. Apart from SVV, it also calculates stroke volume and cardiac output and SVR. So the three parameters of the cardiac output, preload, afterload, and contractility, can be easily assessed with the help of flow track. And the important gadget which should be there in OT ICU, that is the echocardiography machine with both transthoracic as well as transesophageal echoes, which will certainly give all the cardiac functions like preload, afterload, and myocardial contractility. Now we will see a case and how to manage in different operations. A 68-year male patient, diabetic hypertensive since 15 years. He is a known case of dilated cardiomyopathy. There is a history of admission for breathlessness in ICU 3 months before. He can climb 2 flights of staircase. Hemodynamically stable at present. Pulse is 86 and BP blood pressure is 110/64. There is mild pedal edema. CVS is showing, CVS examination is showing faint systolic murmur in mitral area, and in respiratory system there are occasional RALs. Echocardiography report is showing global hypokinesia with EF of 20%, grade 2 diastolic dysfunction, moderate MR, moderate PH. The diastolic diameter of the left ventricle is 72 millimeter and the systolic diameter is 67. The LA is 58 millimeter large. There are altered diastolic velocities across mitral valve. Right ventricular and right atrium function is normal. The patient is on diuretic, angiotensin converting inhibitor, carvedilol, amiodarone, and aspirin. Diagnosis is 68-year male with diabetes, hypertension, dilated cardiomyopathy with history of decompensation 3 months before. At present, compensated stable heart disease, not in failure. NYHA grade 2, ACC, AC stage 3. Now this patient has following problems: dilated cardiomyopathy with EF of 20%, history of decompensation 3 months before, moderate MR, moderate PH, and diastolic dysfunction. Now this patient is posted in 4 different surgeries. We have to have this anesthesia plan. Now first, the patient is posted for hemorrhagectomy. In second scenario, the patient posted for radius fracture, open reduction interfixation. In third scenario, the patient is posted for cholecystectomy and patient posted for liver resection. I am assuming that the patient is, we have done the history, clinical examination, optimization of the patient, cardiologist, physician has played their role. They have optimized the patient, medical therapy is given, and you are doing this case in a setup with all equipments, gadgets, and good ICU CSU backup. Now the patient is posted for hemorrhagectomy or radius fracture, open reduction, internal fixation. Now in these 2 surgeries, I can give regional anesthesia with minimal effects on hemodynamics. For hemorrhagectomy, I can give saddle spinal, and for patients for the surgery of radius fracture, I can go for peripheral nerve block, supraclavicular or axial nerve block. Because both surgery and anesthesia have minimal side effects on the hemodynamics, I can have routine monitoring, and accordingly, the patient will be having less cardiovascular complications in the perioperative period. If the same patient is posted for cholecystectomy, it may be open or laparoscopic, I will be expecting hemodynamics changes significantly. So in this patient, I will be using radial artery line, IGB line. The IGB line will be for CVP calculation as well as for giving vasopressors and inotropes. Normally, I start dopamine and noradrenaline in these patients before induction of anesthesia. We call them as preemptive inotropes. Induction will be opioid based, fentanyl injection, fentanyl 2 to 4 microgram per kg or etomidate. The induction should be slow with calculated doses. and titration method. Maintenance oxygen plus air with inhalation agent like sevoflurane. Nitrous oxide we avoid because there is element of pulmonary hypertension, and nitrous oxide with inhalation agents lead to more myocardial depression. Anesthesia is further added by opioid infusion or regional, like if you have put epidural, we can give diluted doses of local anesthetic. You should be always vigilant during important steps of anesthesia like induction, intubation, skin incision, extubation. Potassium should be always on the higher side, 4 to 4.5. To decrease the myocardial irritability, always supplement potassium and magnesium sulfate intraoperatively. The IV fluids are guided by CVP trained and also other parameters like pulse, blood pressure, ET, CO2, urine output. Always manage good depth of anesthesia using general anesthesia with regional technique. Now, the same patient posted for liver resection. I am giving this example. There may be other supramajor surgery like this, where there are a lot of large fluid shifts and we expect a lot of hemodynamic instability. So in this patient, apart from the previous all monitoring, I will like to have a constant monitoring of preload, contractility, and afterload cardiac output monitoring of the heart. So we can go ahead with either echocardiography transesophageal probe or flow track, or if you have Swan-Ganz catheter and cardiac output thermodilution technique, we can also calculate the cardiac output, stroke volume, and PA pressure, pulmonary capillary wedge pressure, and accordingly we can guide the fluid therapy. So according to need of the patient and patient surgery, we will have a number of other monitors and which will be helping us in the managing of these patients in perioperative period. Now, patient with ICD, internal cardiovascular defibrillator. So in these patients, the patient's pacing function of the ICD should be converted to asynchronous mode, and the tachytherapy of the ICD should be inactivated before the patient is posted for surgery when the surgeon is going to use cautery. Same way, a patient with CRT, that is cardiac resynchronization therapy, the pacing mode should be converted to asynchronous mode. In the post-operative care, there should be careful fluid balance and analgesia. The same monitoring what we have used in the intraoperative period should be followed in the post-operative period. Even for minor surgeries, there should be a low threshold for admission to ICU and HDU. When the patient is shifted to ICU, CCU, you should give a good over to the staff and physician what fluids you have given, what inotropes you have used, what are the various events, any significant events in intraoperative period, so that these people of ICU staff and the doctors over there, they will know what is the general condition of the patient. There should be proper notes and documentation of everything. And after the patient is transferred, you should always discuss with the relatives about the patient's condition. Thank you. I have finished my presentation.
Thank you, sir, for the very illustrative and wonderful session on understanding the physiology of the heart failure and anesthesia concerns for the same. Now, our next topic is the coagulation cascade, and it will be presented by Dr. Pritesh Kumbhare. So I request him to proceed for the same.
Hello, am I audible now?
Yes, sir. You're audible.
Okay. So let's start with the physiology of the coagulation. So as we all know, Rudolf Virchow first suggested the coagulation triad of endothelial injury, hypercoagulable state, and the circulatory stasis. So the important components of the hemostasis are firstly endothelium. Any injury to endothelium will cause the platelet activation and the aggregation, which will form the temporary platelet clot, and then the coagulation proteins which will take part in the coagulation cascade to form a stable clot. So mechanism of the blood coagulation, it is a physiological balance which exists between the factors which promote the coagulation, those are procoagulants, and the factors which inhibit the coagulation, those are anticoagulants. So coagulation of the blood depends on the balance between these two factors, and disturbance in any of this balance could lead to either thrombosis or bleeding. So clotting factors, phospholipids and platelets are the procoagulants in the body, and the anticoagulants are the natural inhibitors like antithrombin 3, protein C and protein S, and the fibrinolysis or the clot resolvement method or the process. So what is hemostasis? It is the prevention or the stoppage of the blood loss, and the hemostatic mechanism involves the following stages. So firstly, the vasoconstriction of the vessel wall will occur, which will further prevent the blood flow. Secondly, platelets production and the activation, which will form the and the aggregation, which will form the platelet plug. Thirdly, the blood coagulation, the clot formation with the help of the coagulation cascade, intrinsic, extrinsic, and the common pathway. And finally, the clot lysis or the fibrinolysis. So as you can see, there is a vessel wall injury, and the exposure of the collagen will cause the platelet adhesions, activation, and the aggregation, which will form a primary hemostatic plug. Now the activation of the blood coagulation cascade will form the thrombin, fibrin, and form a stable hemostatic plug, as I already mentioned. So the coagulation cascade. As you all know, it includes the extrinsic pathway, the intrinsic pathway, and the common pathway. So the extrinsic pathway, which starts with the tissue factor, thromboplastin, and it enters into the a common pathway which activates the factor 10 to a 10A. And similarly, intrinsic pathway, which starts with the exposed collagen and the damaged endothelium. Again, it activates the finally it activates the factor 10 to 10A, and which leads to the final step of the coagulation cascade, which is conversion of prothrombin to thrombin, which will stimulate the fibrinogen to convert into fibrin monomers. And with the help of factor 13, then fibrin monomers they get converted into fibrin polymers, which forms a stable clot. Let us see some commonly used antiplatelet agents, various mechanism of action of these drugs. So firstly, aspirin. So it works on the COX enzyme, which inhibits the conversion of arachidonic acid to prostaglandin H2, which further stimulates the thromboxane A2 for the platelet aggregation. Secondly, we have something called as ADP P2 Y12 receptor antagonist, and the drugs that we know are that we use commonly are clopidogrel, ticagrelor, or triclopyridine, and prasugrel. So they inhibit the ADP, the binding of ADP with the P2Y2 receptor, and thereby it inhibits the clot formation. Thirdly, we have glycoprotein 2B3A inhibitors. The drugs are apiximab, eptifebetide, tirofiban. They inhibit the binding of fibrinogen to the platelet. Now, the recent class of drug that we have is something which acts on the phosphodiesterase enzyme, which stimulates the cyclic AMP and inhibits the platelet aggregation. The cyclic AMP also causes the vasodilatation. That's why these drugs are now being used for the peripheral vascular diseases. The drugs are dipyridamole and cilostazol. Quickly, we'll see the classification of the anticoagulants. So firstly, vitamin K antagonist, mainly warfarin is that what we use. Heparin and heparinoids. So that includes your low molecular weight heparin, unfractionated heparin, and the oligosaccharides like fondaparinux. There are direct thrombin inhibitors, which are either bivalent or univalent. Bivalent, bivalirudine, lepiridine, and univalent are dabigatran, agrobatran. Now there are newer anticoagulants that we have which directly acts on activated factor 10A, like apixaban, endoxaban, and rivaroxaban. So as you can see in the coagulation pathway, unfractionated heparin and the low molecular weight heparin, they are the indirect inhibitors of factor 10A, which works via antithrombin 3. Similarly, fondaparinux also is an indirect it's an indirect anticoagulant because it indirectly acts on the factor 10A. Now we have vitamin K antagonists. As you all know, vitamin K dependent factors are 2, 7, 9, and 10. And warfarin, which is a vitamin K antagonist, it works on these factors. We have newer oral anticoagulants, which works on factor 10A, as I've already said, as this name, and it works on this step of the common pathway. Similarly, dabigatran is a newer anticoagulant, and it works on directly on the activated factor 2A. That's it. Thank you.
Thank you, Dr. Pritesh, for a nice presentation on physiology of a coagulation.
Thank you.
Now, for all the participants, please put your questions in the chat box that will be answered at the end of session. Now, let's move to our next topic that will be covered by Dr. Supriya Kulkarni. She is a consultant at Maharashtra Medical Foundation, which includes the Joshi Hospital and Ratna Memorial Hospital. And her topic is anticoagulation and anesthesia. So I request Dr. Supriya Kulkarni to start with her presentation. Hello.
Hi. Am I audible?
Yes, you are audible.
Yeah. Initially, I would like to thank Dr. Pradna ma'am, Dr. Sushma ma'am, Dr. Sandeep Patel sir for the opportunity of presenting this topic. Dr. Pritesh has already very.
Ma'am, we are facing some, like we have some voice disturbances, like we cannot hear you.
Ma'am, 1 minute.
Yeah.
Ma'am, can you hear me now?
Yes, you are audible.
Dr. Pritesh has already explained about the physiology of coagulation. I would like to continue with the clinical application of that particular knowledge because most of the times we face the challenge of managing patients who are on anticoagulants and they're posted for various surgeries. Besides, the reasons for anticoagulation treatment are varied in various patients. So the balance between reducing the risk of thromboembolism and preventing excessive bleeding is the target in management of such patients. It is achieved through an interprofessional approach amongst anesthesiologists, surgeons, physicians, and cardiologists, sometimes neurologists as well. Thorough pharmacological knowledge about the anticoagulant drug being used, its indication in the concerned patient, extent of bleeding anticipated in the surgery, role of neuraxial anesthesia or deep plexus regional anesthesia, expected duration about resumption of anticoagulation post-operatively are the important aspects in perioperative management of these patients. So first of all, we'll see what are the grossly what are the indications about anticoagulant or anti-aggregation drug use. As we all know, the most common indications are in the cardiac patients. But apart from that, the venous thromboembolic episodes in any patient or the risk of systemic embolism due to deep vein thrombosis is also a very common cause of prophylactic anticoagulant use. So the list here is atrial fibrillation, deep vein thrombosis, pulmonary embolism episode already occurred, venous thromboembolic episodes, and the risks of venous thromboembolism are there in many patients like morbidly obese patients, pregnant patients with obesity, hip or knee replacement surgeries, patients on cancer treatments, recumbent patients or the non-ambulated patients and such indications. Apart from that, unstable angina, prosthetic heart valves, cardiac chamber thrombus, episode of ventricular tachycardia or fibrillation, post-PTCA, ischemic heart disease patients, patients with ischemic or thromboembolic stroke in past, and peripheral vascular disease patients require these drugs. Various anticoagulants in clinical use, Pritesh has already enlisted. I'll just summarize that there are thrombolytics like streptokinase, urokinase, fibrinolytics, low molecular weight heparins, unfractionated heparin, anti-factor 10 agents. These are the novel anticoagulants group about which I would like to quote just 2-3 statements that this group was invented in view of reducing the harms or the pitfalls with use of warfarin treatment. Fondaparinux, rivaroxaban, apixaban, betrixaban, and dabigatran as well are the agents agents which are quite in clinical use these days, like in last 10 years. And these agents have a better pharmacological profile. They have got early onset. They require lesser monitoring, and they're more potent in their functions. Vitamin K antagonist warfarin is the most anciently used and also a potent anticoagulant. Antiplatelet agents we have are NSAIDs, which include aspirin mainly, and the function is also there with ibuprofen, diclofenac, indomethacin, but to a very weaker extent. We have thienopyridines, ticlopidine, clopidogrel, prasugrel, ADP inhibitors like ticagrelor and congrelor. Congrelor is an agent which is recently added, more recently added, and it has got a very short half-life of around 4 to 10 minutes only. So it has got its certain advantages of itself. GP2B3A inhibitors are abciximab, eptifiban, and tirofiban, which have got role especially in the acute coronary syndrome. Phosphodiesterase inhibitors we have like cilostazol and dipyridamole, and herbal therapies are also there. The surgical procedures, like now the assessment when we are dealing with a patient who is already on anticoagulants, now he's planning to be posted. We have some time in our hands, or we don't have. We are in both the situations most of the times, but we are supposed to firstly classify about the safety of the classify, or we have to prioritize firstly the safety of the patient regarding bleeding or thromboembolism, which risk is going to face more, or how we can reduce the risk. And apart from that, we are also concerned with the need of the surgery, the urgency of the surgery also, and type of procedure, and discussion about it with the surgeon is very essential here. So we have like knowing about low bleeding risk cases can make us more comfortable, and we can continue with the anticoagulants, and the stress is less upon us. So these surgeries are hernioplasty, incisional hernia, laparoscopic surgeries, luckily, breast surgery, hand surgeries, arthroscopy, cystoscopy, tooth extraction surgery, digestive tube endoscopies, including gastroscopy, even ERCP, and cataract surgery. Intermediate bleeding risk surgeries are hemorrhagectomy, splenectomy, gastrectomy, gastroplasty, knee and shoulder repairs, otorhinolaryngological cases, orchidectomy, and prostate biopsy. Whereas the most concerned surgeries for us in this category are neurosurgery, posterior high chamber surgeries, hepatectomy, pancreaticoduodenectomy, radical prostatectomy, and even other major radical malignancy surgeries, transurethral resection of prostate, nephrectomy, hip replacement revision surgeries, and spine surgeries. Here, the another category, which is posterior eye chamber surgeries, which can also bleed, and that particular bleeding is more of a concern about vision of the patient and the eye health post-operatively. Now, apart from this, now we have anticipated a risk of high bleeding and or even intermediate bleeding category surgery, but we cannot completely stop the anticoagulation in certain patients in certain classes. So for them, we have the option of bridging anticoagulation. It is the substitution of a long-acting anticoagulant, usually warfarin, sometimes even dabigatran nowadays, with a short-acting anticoagulant to limit the duration of subtherapeutic anticoagulation levels and minimize thromboembolic risk. How to bridge? We discontinue warfarin 5 days before surgery. Start with an unfractionated one or LMWH as per the renal function of the patient, the cost effectiveness, or the choice of the physician also many a times. We assess INR 2 days prior to surgery. It should be less than or equal to 1.5. We discontinue low molecular weight heparin 24 hours prior to surgery, and if it is unfractionated, then 6 hours prior to surgery. And decision of starting back warfarin depends upon how critical the bleeding is anticipated in post-operative period. It can be 12 to 24 hours with low risk anticipation post-operatively of certain surgery, or 48 hours after the surgery, bleeding is anticipated till then. Injection congrelor can, like I have already mentioned, it can also be used as this ADP inhibitor has got a short half-life of 3 to 5 minutes. So 5 minutes. The indication for bridging anticoagulation are patients with mechanical heart valve with additional risk factors like stroke, TIA, cardioembolic event, or intracardiac thrombus. Patients with AF plus additional risk factors, the chat to DS2 VAS score more than 6, patients with recent coronary stenting within the previous 12 weeks, patients with stroke, episode of systemic embolization or VT during last 3 months. Now we just talked about this bridging anticoagulation, how to do and whom in with which patients to be done. But what the research literature in last few years say, it is there are studies like Bridge, Rocket, Orbit, and Dresden Registry. Most of them are not RCTs. It is not ethically permitted to do RCTs for this cause. A few observational studies and meta-analysis there about bridging, which all conclude that it is not useful in any of the cases. It was not significantly useful. Rather, in a few cases, it caused bleeding, and in a fewer cases, it led to death also. So again, it's a matter of clinical judgment and interprofessional discussion, and to be decided like as per the patient, as per the requirements, and as per the experience of the certain clinician involved. Now, what are we concerned most while talking about anticoagulation anesthesia? It is the neuraxial anesthesia. And what are we scared of, or what is the nightmare for an anesthesiologist? It is the spinal epidural hematoma in a patient whom we have handled the neuraxis. Like we have given spinal or epidural anesthesia, and patient has got a spinal epidural hematoma. It's a symptomatic bleeding inside the vertebral canal. It's a rare and potentially catastrophic complication of neuraxial anesthesia. Even if the most common cause of this bleeding is idiopathic, still neuraxial anesthesia accounts for second most common cause. More frequently, it occurs in epidural space due to abundant venous plexus, large size of epidural needle, and catheter trauma. It is known to be lesser with spinal anesthesia. Besides, a very important point is it is more with the epidural catheter removal than even insertion. The incidence is known after catheter removal in most of the patients who have received epidural, who have recorded of getting an SEH. Incidence rate is reported to be 1 in 1,50,000 epidural punctures and 1 lakh to 22 lakhs of spinal anesthesia. I'm sorry, 2,20,000 spinal anesthesia. But this is an under-reported rate, and it is much higher with injection enoxaparin and oral agents like dagabatra and dipyridamole. The case reports emerging are saying so. Clinical manifestations of this spinal epidural hemorrhage are slow or no reversal of the motor or sensory blockade. There is severe back pain complaint by the patient, a very alarming sign. Urinary retention of sensory or motor deficit after complete reversal of blockade. Now, to know about, like, it's a confusing state that we're already providing epidural infusion to the patient, and then how to assess the motor function or the whatever the sensory deficits there because of the SH. Back pain is one thing. Apart from that, use of lower concentration of local anesthesia is recommended for detection of abnormal motor blockade, because with especially the good agents like ropivacaine, the 0.125% bupivacaine like things, we will have almost complete recovery of motor function of the patient. And now if we are noticing there is sustained motor block or newly emerged motor block, then we have to be suspicious about a spinal epidural hematoma. Aggressive diagnostic and therapeutic strategies, of course, mandatory, as it's a neural thing. MRI is the conclusive investigation to be done. Decompression laminectomy within 6 to 12 hours of initial symptoms can give complete neurological recovery as per reports. But still, it's a very big medico-legal as well as on the patient's part, increased hospital stay and increased morbidity are all the concerns we have to worry about. It is not the thing that general anesthesia is completely free of complications, because many times we have the choice of general anesthesia in freshly anticoagulated patient or patients in whom it is not possible to stop anticoagulation. But still there are a few concerns, like there is no, we should not go for an intramuscular subcutaneous injection. If it is unavoidable, use arm as bruising will be visible earlier. Avoid IJV or subclavian vein lines if necessary. Use EJV or anterior cubital vein. Avoid nasal intubation, nasal airways, and nasogastric tube insertion as far as possible. A traumatic laryngoscopy and tracheal intubation should be attempted. There are case reports, profound airway bleeding requiring tracheostomy with use of apixaban. With warfarin, we have case reports of airway bleeding, which was not under general anesthesia. It was just with violent cough also. So we have to be careful about airway bleeding, which will be another disastrous complication and an immediate risk or imminent risk to patient's health, the life rather. There are some situations in which urgent or emergency invasive procedures are to be done. So what can be done in these situations? We have an option of reversal of the anticoagulant defect in major emergency surgeries with anticipated bleeding risk. As there is thrombotic risk with such products, their use should be limited in intracranial hemorrhage, post-prostatic surgery bleeds, renal trauma, etc. And like even if we have options of reversing the anticoagulants, a few of them, like it has to be a decision weighed against anticipated hypercoagulability, because surgical stress is already a situation which is going to give a hypercoagulable state to the patient. It's an inflammatory state of the patient. Agent specific reversal options are for warfarin, vitamin K in semi-urgent situations, and prothrombin complex concentrate, which consists of factor 10, 9, and 2, or fresh frozen plasma in emergencies as per INR value. Dabigatran, its effect, it's a long-acting one, a potent one. Effect is reversed with injection. Idarizumab, rivaroxaban, apixaban, and endoxaban are reversed with andixanate alpha or a PCC, again the prothrombin complex concentrate. Heparin, unfractionated one, injection protamine sulfate. For LMWH, the reversal is not complete with protamine sulfate, but partially, yes, it is there, which can later be it can be checked with factor 10 anti-factor 10 levels. For the platelet aggregation, the drugs which are anti-aggregant, like the platelet inhibitors, for them transfusing them with platelet concentrate, fresh platelet concentrate, is an option. This coagulation function of these drugs is required to be monitored, like the pre-op monitoring, in certain cases even intra-op, the major bleed anticipated cases. For unfractionated heparin, we monitor with activated partial thromboplastin time, activated clotting time, anti-factor 10A levels, and platelet count. For LMWH, monitoring required less frequently, mandatory in renal failure cases, because its elimination is completely renal, and with less renal clearance, LMWH gets accumulated. Besides, it gives longer acting effect of anticoagulation. The preferred test is anti-factor 10A levels, warfarin, PT, and INR. For dabigatran, thrombin time, rivaroxaban, prothrombin time, using a thromboplastin that is sensitive to rivaroxaban. Antiplatelet drugs, platelet function assessed with point-of-care diagnostic tools like thromboelastography, sonoclot, rotational thromboelastometry, platelet function analyzer. For antiplatelet drugs, platelet count or even bleeding time are not considered to be the useful tests. Certain concerns in pregnant patients. Even though pregnancy is a state of hypercoagulation, thromboembolic events have a low incidence in perigestational period. Common risk factors for increased chances of thrombotic events are age above 35 years, prolonged immobilization, obesity, previous thromboembolic event, autoimmune coagulation dysfunctions like Appler syndrome or cesarean section. The comparatively lower incidence of hemorrhage, neuroaxial hemorrhage in obstetric population is assumed to be due to relatively hypercoagulable state of pregnancy. The general guidelines for use are same like other categories, but here, considering the maternal-fetal safety profile much better in spinal anesthesia, and even the use of epidural analgesia much helpful in especially the cardiac risk patients, we have to weigh the risk-benefit ratio and prefer our anesthesia. Deep plexal peripheral anesthesia, the guidelines are similar, just like neuroaxial anesthesia, but there are a few changes, like risk of bleeding in deep plexal blocks remains undefined. There are no certain studies or the case reports. A few case reports are there which tell about hematomas describe satisfactory nerve function recovery between 6 and 12 months. The recommendations say that ASRA recommendation that 32 cases of bleeding in regional blocks, out of which 18 patients were on anticoagulants, remaining were not on anticoagulants, but still they bled. One death out of these cases during deep plexus block procedure without USG guidance, it was done. Some recommendations like neuroaxial anesthesia, same recommendations for superficial blocks. Anesthesiologists should consider the local compressibility, vascularization, and consequences of bleeding. For superficial and deep plexus blocks, ultrasonography is suggested by the ASRA task force. The guidelines, I won't go into the details. I know like quite an extensive description. So the level of evidence is RCT and meta-analysis, observational epidemiological series and case reports and expert opinions. These guidelines, we have even a few other guidelines like those by the Brazilian Society of Anesthesiologists and a few others, more or less similar. The 2018 revision of these guidelines tell us about the novel anticoagulant use like dagabatran category rivaroxaban. Besides, they have reduced the clopidogrel stoppage for 5 days rather than 7 days. These guidelines tell us about how much duration before neuraxial anesthesia to a patient who is already on anticoagulants, when to remove the catheter, and after removing the catheter, how much duration to be taken to initiate the anticoagulation again. So it has to be followed by heart because these values are there to guide us about maintaining that hyperthrombotic versus the bleeding risk. My last slide, near about the last slide, I'll say it's about after learning this much, what should be our decisions? Like 65-year-old male patient, known case of diabetes, hypertension, IHD, undergone PTCA for double vessels. Patient is on dual antiplatelet therapy with clopidogrel and aspirin. With TAP clopidogrel aspirin, he's posted for cataract surgery. What should be our decision? Like I would have liked to keep it an interactive session, but because of the online thing, not possible right now. But I'll say that what we have learned, I didn't mention in the last slide, but the thing is, aspirin has no contraindication. Like aspirin is recommended to be continued, but only if it is the sole antiplatelet drug used. If it is in the dual form, the potency of anticoagulation is more now. So, but cataract surgery comes under a low risk category. So for these cases, and if the PTCA is done within last 3 months, yes, we can continue with aspirin at least, even if not clopidogrel. We can omit clopidogrel 5 days prior and go with aspirin. And after the cataract surgery, with discussion with our ophthalmologist, we can resume back with the DAPT around 1 week after the surgery. A 32-year female with RVHD undergone prosthetic mitral valve repair 4 years back on TAP Warfarin, posted for elective cesarean section. A very common scenario faced by most of us. In this scenario, we go with changing the Warfarin with heparin 5 days prior to surgery, then LMWH preferably. Then 2 days before surgery, we check for the PTNR to be less than 1.5, and then we post the patient. Postoperatively, heparin can be restarted after 48 hours, and we can safely give spinal anesthesia in this case by stopping the prophylactic dose of Clexane 12 hours prior to surgery and initiating it 12 hours after the surgery. A 55-year-old male known case of atrial fibrillation or DAPT with TAB aspirin and TAB rivaroxaban posted for emergency craniotomy. Now this is an emergency situation with a big bleeding risk, and that too the central nervous system. So what patient is on dual antiplatelet therapy, aspirin and rivaroxaban. So the most important option in our hand is platelet concentrate, transfusion of platelet concentrate to the patient after assessing the platelet function with thromboelastography or sonoclot like testing methods. 70-year-old male known case of hypertension, episode of stroke 1 year back on TAP Agrinox, that is aspirin plus dipyridamole. I would like to mention that dipyridamole is known, it's a very high risk drug, even if it is a good potent one, but it's a high risk drug for neuraxial bleeding and even the surgical site bleeding. It is to be omitted 24 hours prior, but still this drug has got potency to cause bleeding. So these patients will require the platelet concentrate prior to the incision, or at least along with the incision, platelet concentrate has to be given to the patient to optimize the bleeding situation and to conduct the case safely. Like I have already mentioned these things, the interprofessional discussion, balancing the risk, and being aware of the spinal epidural hematoma. Thank you very much.
The applied clinical pharmacology of the anticoagulant drugs and anesthesia, and the management of complication for the same. Thank you. Now with this, we have completed our 4 presentations of the webinar. Now let's move to the question answer session. Now we have, hello, am I audible?
Yes.
Yeah.
Yes.
Yeah, you are.
Yes. So, so there is one question in the chat box for Sandeep Patil sir. Comment on a patient with a good ejection fraction but a diastolic dysfunction.
This is the subset of patients having clinical signs and symptoms of heart failure, but the ejection fraction is normal. Now it is due to the diastolic dysfunction. If this patient comes for anesthesia management, now most of the time, this diastolic dysfunction patients, they have given treatment in the form of beta blocker and angiotensin converting enzyme inhibitors. Why this treatment? Beta blocker will reduce the heart rate, and angiotensin converting enzyme, they are useful in cardiac remodeling. Now the diastolic dysfunction heart is less compliant. It requires more end diastolic volume to get filled. So if the heart rate is less, so when there is tachycardia, the diastolic time is reduced. Now in this on beta blockers, the heart rate is less, and so the left ventricle gets more time for getting filled up, and angiotensin converting enzymes will help in decreasing the afterload and the remodeling of the heart. So this is very commonly seen, the diastolic dysfunction grade 1, grade 2. Now these patients, when posted, if they go into cardiac failure status, then they may be on diuretics. So these 3 treatments are there. And when they are posted for surgery, we have to anticipate the interactions of these beta blocker angiotensin converting enzyme inhibitors with our anesthesia drugs. And they are very safe to give general anesthesia, but they are not that bad as compared to systolic dysfunction less than 30%. So is my answer is okay? Who has asked the question?
Pradna ma'am.
Okay, ma'am, is anything more you want to ask?
No, thank you. This
Thank
was
you,
for everybody in general.
Yeah.
Because often we have patients who have a 60% ejection fraction, and our juniors will tell us, Madam, ejection fraction chane. But they don't look into the echo for the diastolic part, which is equally or more important actually. Yeah.
Certainly. Diastolic dysfunction and systolic dysfunction, they commonly exist together. And diastole is also a procedure which requires energy. So in ischemic heart disease patients, both these conditions are present. So most of our patients' echo reports will be elaborating on this diastolic dysfunction.
Okay, sir. Thank you, sir.
Thank you.
Sir, I would also like to know whether the cardiac output monitoring is essential for every patient with the low ejection fraction who are posted for major surgery.
It depends how much compensated your heart disease is. Okay. And depending on the complexity of surgery. If your patient's preoperative status is absolutely stable, his heart rate, blood pressure, and if you are planning for some major surgery, which is having more hemodynamic effects, so in that scenario, depending on need, what I already told you, invasive artery, at least radial artery, and a central line will be necessary for managing any hemodynamic alterations in the perioperative period. Cardiac output can be judged clinically. Pulse, blood pressure, it is CO2, can be your routine monitoring can help us to know about what is cardiac output. But the flow track monitor or Swan-Ganz catheter, they can be needed only in very supra-major surgeries. They will be more useful. In the routine major surgeries, I think the invasive monitor like radial artery with central line will be more than sufficient.
Okay, sir. Thank you, sir. We have a next question for Dr. Supriya. The question is, what about the emergency surgery in patient who is on warfarin?
Yeah, like one of the case scenarios can be like emergency surgery, patient already on warfarin. So assessing PTNR of that patient, and of course, the target INR is around 3 in warfarin patients. We can go for transfusing fresh frozen plasma or the PCC, that is prothrombin complex concentrate. Honestly, I don't know our blood banks provide it easily or not. I haven't used yet, but FFP transfusion and oral vitamin K or use of intravenous vitamin K can be the optimizing things for such patients.
Okay. Thank you, madam. We have another comment. Can we, by Dr. Prajakta, can we take an informed written consent and go ahead with regional anesthesia, where general anesthesia too carries a risk and INR is marginal?
Yes, exactly. The guidelines are the approximate. It's just it is showing us a way to go ahead, but it is not like that's the only medical legal thing to be followed or something. It is case to case. It is on case to case basis, and clinical judgment will be the key. So, in patients who have issues regarding general anesthesia, or they have more risk in conducting general anesthesia for them, like the COPD patients or any many other categories, for them explaining the risks and taking consent is an option. This is because the occurrence of SCH is very rare. Like, we still can say it is rare, but still optimization of the bleeding, the clotting function, and these things can be done parallelly, and we can take consent and go ahead for regional anesthesia. Rather, it is recommended with ASA task force. The bottom lines are that it has to be done with obstetric patients and even in other high-risk patients for general anesthesia.
Okay.
There are actually papers in literature also, what Dr. Supriya is telling. Patients on this INR on the higher side or antiplatelets, but the benefit risk ratio is in favor of giving regional. So in that scenario, you can go ahead with regional, because the mortality what you are facing with general anesthesia is on the table. But the assumption that developing of spinal hematoma will be a rare possibility even after if the patient is on antiplatelets. So you can, what you have said is rightly. You can explain the patient what you are doing, and certainly can go ahead with regional anesthesia.
Okay, sir. Thank you, sir. This question is for Sandeep, sir. Sir, in patient with a low ejection fraction, is CVP reading is a reliable marker for a preload or a left ventricular and diastolic volume?
This is a typical gray zone, but it is proven beyond doubt that CVP, central venous pressure, is a pressure, not a volume. It is a fixed variable. So CVP is mainly for right side of the heart, and for left side it is PCWP, the pulmonary capillary wedge pressure. If your both ventricles having normal function, then indirectly we can assume that central venous pressure may be giving you left-sided picture of volume status. But the ideal is always a dynamic variable, like a stroke volume variation, what we have talked about in flow track. And you don't see the CVP will be giving you what information. You have to see the trend. The baseline CVP is 8, and you are given fluids. Now it is now 9. So the figure is not important. The trend I can use for infusing fluids. But CVP, it is proven beyond doubt, it is not the marker or the ideal marker of left-sided or fluid status of the heart. It is left-sided for pulmonary capillary wedge pressure or IVC collapsibility on the echocardiography, IVC diameter, IVC collapsibility, or echocardiography. You can see directly the left ventricle, the contractility and the emptiness of the left ventricle, and flow track SVV, that is stroke volume variation. These are the ideal things to know the volume status.
Okay, sir. Thank you so much, sir. The one question for Dr. Supriya. What are the recommendations for patients who are posted for ERCP or OGD scopy for variceal binding?
OGD and ERCP patients are categorized in the low risk ones. But besides the general guidelines also categorize them in continuing with aspirin and not about even discontinuation of warfarin also. But in my observation, most of the gastroenterologists or the surgeons, they prefer to stop the long-acting anticoagulant before proceeding with ERCP. But if we are there for the decision making, and even physician allows us to go along with the anticoagulants, and the consultant is comfortable in doing the procedure, then actually the guideline is continuing the anticoagulation, even if it is a potent one, even if it is a long acting one.
Okay.
Can I add one point?
Yes,
Sir,
yes.
yes, sir.
Always think why they have started this anticoagulant. It may be for a stent or it may be for prosthetic valve. So what is the duration from that particular, if the valve, this stent is before 5 months, then continuing the dual antiplatelet may be more beneficial than stopping it in these low risk surgeries. Same time, prosthetic valve, your patient is on warfarin. So stopping it, can block or the valve, there will be clot on the valve and the patient may die on the table. So we have to always judge the benefit and risk and what is the type of surgery. So always go accordingly and then take the decision with discussion with cardiologist and your physician and surgeon.
Okay, sir. Sure, sir. Any more questions from the participants? There are no more queries or question in the chat box. Pradna madam, can we conclude the session?
Yes, you should. You can conclude the session. Sandeep, thank you very much for being there.
Thank you,
Yes.
ma'am. Thanks a lot.
Ma'am, thank you.
Yeah.
I sincerely
Ma'am,
appreciate.
you can conclude. Yeah.
Yes, ma'am. Sincerely appreciate all the presenters on behalf of ISA Pune City branch, and would like to thank all of them for their wonderful and very elaborative presentations, which were really clinically useful. And thanks to all participants for their patient listening and the cooperation. So with this, I would like to conclude the today's webinar. Thank you.
Thank you.
Thank you. Thank you.
Pradna madam.